Assalamualaikum ji. Acha, now we are, matlab ye function of the heart we cannot cover in half an hour. It's an ongoing thing और रोज़ बंदा इसमें नई चीज़ सीखता है. अभी जैसे कुरैश साहब ने बड़ा मज़ेदार पॉइंट, वेरी डेलिकेट पॉइंट बताया. So now we move towards the diastolic function. So for diastology, we need a worksheet. We need, like as we were doing for systology, there are different things which were needed. For diastology, there are different things which are needed. The point of making this an important here is because a lot of the times we do see people not commenting on diastology. And even if they are commenting on one or two parameters, and during my talk you will see that at least there are 4 parameters on which we should be commenting. So we should be commenting on E wave and A wave transmittal flow velocities, then E to A ratio, E prime, E by E ratio, TR velocity, pulmonary veins, as Dr. Nusrat would beat us if we don't comment on pulmonary vein. So there are and नहीं मैं पल्मी वेन पे मैं पल्मी वेन को I'll just touch upon that. मैं सिर्फ ये कहना चाह रहा हूँ कि हम भूलेंगे नहीं उसको. So and you know in the red there are the cutoff values. So now when I have told you there are so many parameters, but there are some parameters which are very sensitive and some which are very specific. And E prime is a most sensitive parameter when we are describing the diastology. Mitral endless early diastolic velocity or E prime is reduced in all form of myopathies. We have to remember that. There are couple of caveats there, left bundle or other things where we can consider otherwise, but in all form of myopathies E prime is reduced, so we have to remember that. And this is based on the Norris study on which our guidelines were based, and we know that in all the age groups 20 to 40, 40 to 60 and more than 60, E prime has always been more than 5. It's always. Similarly, E by E ratio in all the age groups from the same study, it has been found that it's always been less than 14. So if we remember these two things and one more specific parameter, I think my purpose of the talk is done. So remember that grade 1, grade 2, grade 3 abnormalities, and in all of them we have to remember that E prime is reduced. Similarly, the most specific parameter, that is the TR velocity. And this is again based on the same study, and it has been found that TR velocity of more than 3.36 or TR velocity of more than 2.8 is found in 0.3% of all the participants in that study. So it's very, very rare to have a TR velocity of more than 2.8 and it to be normal. So this is the most specific parameter. So if you got these two parameters, and I'll come to that why I'm stressing on these two parameters, because there are 4 parameters and we are stuck most of the times as an indeterminate when 2 are positive, 2 are negative. But I think if you have these 2 positive, then probably diastology is abnormal. The problem with the TR velocity is that how feasible is it? In the study where the feasibility of echo parameters was done, I think this is no pointer कौन सा है इसका pointer इसका नहीं चल रहा ये बहरहाल TR velocity कहाँ से pointer okay अच्छा so you see here that TR velocity feasibility is 75%. And in two studies done while validating these things, one European study and one an American study, one by Lancelotti, European study, they found the feasibility of TR detection is 40%. The American study says that it is 60%. So most of the times, whether you will not get a proper TR or you will not get a properly aligned TR. So there becomes the problem. And I have one solution made by myself, and I'll tell you how to deal with that. Then there are other things which we need to know. That is the LV hypertrophy. We have to look for the LV mass index. We have to look for the LA volume index. And we have to see what is the prevalence. You see that the LV hypertrophy is about 30% and LV concentric remodeling is about 25% in HFpEF patients. Similarly, more than half of the patients with HFpEF have abnormal LA volume index. So we have three algorithms to define diastology, and there are four major diagnostic parameters. The E velocity, which should be normally more than 7 and abnormal is less than 7, medial and lateral is more than 10. E by E prime should be normally less than 14. Again, you have seen that these are based on solid studies. TR velocity is less than 2.8. It's very solid study, again backing it up. And left atrial volume index less than 34. So you see all these things here. Dr. Nusrat would say that we are using her pulmonary veins, but we have to see them. We have to see isovolemic relaxation time, especially in difficult situations. I'll tell you in IVRT, in MAC, we have to rely on IVRT. Then we have to use Valsalva in indeterminate cases. We have to use the diastolic stress echo, and we have to do the LA strain in indeterminate cases. So algorithm 1 is that when the E velocity is less than 7 and medial and lateral is less than 10, average E by E is more than 14, LA volume index is more than 34, and peak TR velocity is more than 2.8. So if you have majority of them abnormal, then that is grade 1 abnormality or diastolic dysfunction. If you have majority normal, then you have normal diastolic function. Most of the times we can fix the patients in one way or other, but about 1/3 of the patients would have half of them abnormal and half of them normal, and we call them, as per the guidelines, indeterminate diastolic function. And during my talk I'll tell you how to overcome that limitation. E to A रेशो की ख़ास कोई वैल्यू नहीं है एज़ पर आवर गाइडलाइंस, वो कहीं आती नहीं है, सिवाय इसके कि रिस्ट्रिक्टिव पैटर्न में जहाँ पे मोर देन 2 आ जाती है तो वो उसमें कहते हैं कि हम रिस्ट्रिक्टिव पैटर्न है, मगर उसमें भी आपको अगेन ई प्राइम तो फिर भी देखनी पड़ती है, बिकॉज इन यंग इंडिविजुअल्स एथलीट्स दैट कैन बी एबनॉर्मल एंड ई प्राइम इज़ नॉर्मल, सो वो उसकी वैल्यू फिर वहाँ पे कम हो जाती है. सो एज आई हैव टोल्ड यू, इफ़ यू हैव majority abnormal, that is diastolic dysfunction. Majority normal, that is normal diastology. But remember that E prime is reduced in all forms of diastolic dysfunction. Then we can do the longitudinal strain, as Dr. Tipu was telling, and that can help us in deciding, apart from systolic function, also that there is diastolic abnormality. I would not talk more on that because Dr. Tipu has very elaborately discussed that. The other thing which I would like to discuss is the left atrial strain, because for those kind of indeterminate diastology patients, we are nowadays using more and more left atrial strain, and probably they would be part of the guidelines as more and more data is collected. And generally the left atrial strain is a mirror image of the left ventricular strain. You have to see the reservoir strain and the pump strain, and the values less than 16 are abnormal. So if you get the left atrial strain, then probably most of the cases would be fitting in one way or other, whether they are normal or abnormal diastology. Okay, so now we see here I would like people to participate in this thing, that this is a patient who has left ventricular volume index is normal, TR velocity is less than 2.8, E prime is normal. So whether this is a normal diastolic function or grade 1 abnormality. So I would like juniors at least to comment on that. Levy is normal, TR velocity less than 2.8, E prime is normal. So how would you call that? Normal. Very good. Okay, then we move to the second algorithm. And like when you are learning, you are doing step by step, doing algorithm 1, algorithm 2. But when you are performing the things, then all the 2 algorithms come automatically in your mind, and you are defining that diastology is abnormal and filling pressure is normal or not, because the algorithm 2 is about the filling pressures. Now, if you have a smaller E which is less than 50 centimeters, taller A, so E to A reversal, which is usually reported in our reports, nothing else is reported, well, that is just a component of that. If you have this pattern and E prime is abnormally small, you go straight that filling pressures are normal. If you have a taller E, smaller A, which is more than 2, and E prime is small, then you have a restrictive pattern and filling pressure is abnormal. So more than 60% of cases would fall into these 2 categories. We are left with almost 1/3 of the patients where we have to apply these criteria, where like these are the cases where E to A ratio is between 0.8 and 2, EA ratio. And we have to look for the E by E prime, TR velocity, and LA volume index. Again, if the majority is abnormal, then the filling pressure is elevated. If the majority is normal, then the filling pressure is normal. But if you cannot measure 3, you can measure 2, 1 is positive, 1 is negative, then indeterminate. Now, here comes the value of LA strain, LA reservoir strain. And this is kind of missing parameter. If we add that, then most of the cases we would be able to define. We have to remember that this algorithm cannot be applied or properly applied in atrial fibrillation, bundle branch blocks, pacings, hypertrophs, severe mitral valve disease processes, high output states. And especially again in these cases, what comes to our help is pulmonary vein analysis, isovolemic relaxation time, and all these things, LA strain. So for the filling parameters, again, just to sum it up, TR velocity is needed, E prime is needed, left atrial strain is needed, mitral inflow velocity to decide whether grade 1, 2, 3, which way it is, and then you can comment upon the filling pressures. So please remember that we have to comment on 2 things, whether diastology is normal or abnormal, and if the filling pressure is normal or increased. Then our comment on diastology is complete. Okay, now the thing which I touched upon in the previous slide was when TR is not there or when TR is insufficient. There is a thing which I have been using, and I have like validated it different ways. What the guidelines say about the pulmonary hypertension in the 2022 guidelines is that we call the TR velocity more than 2.8 as or pulmonary hypertension, and when we convert this 2.8 into systolic pressure, that is 36. So this is equivalent to a mean pulmonary artery pressure of 25. Now what the guidelines say, that RV outflow tract acceleration time of 105 is equivalent to mean pulmonary artery pressure of 25. So if you do not have a TR velocity, you can do the right ventricular outflow tract acceleration time, which can be measured in almost more than 95% of cases very properly. Then if you do not even have TR velocity, you can, I think, fill in with this parameter, and TR velocity parameter would be equivalent to RV outflow tract acceleration time less than 105. So I have been using this and I've tried to validate that, and most of the times it is validated. So if you don't have TR velocity, use RV outflow tract acceleration time. If it is less than 105, then most probably you are dealing with the diastolic dysfunction. So another example, a 64-year-old male is due for cabbage. Like next day he was going for cabbage, and the surgeon said to do his echo as well. He has got severe triple vessel disease, left main, but a normal ECG. Okay, his ECG was normal, his LV function was normal, and look at that, E prime is 8, E by E prime is 7.7, TR velocity is 2.3, left atrial volume index is 27. So is it normal or grade 1, 2 or 3 diastolic abnormality? Remember, he has got very severe disease, is due for cabbage. So what is he? Please bolo yaar. Normal, yes. So having a severe coronary artery disease or some form of heart disease does not mean always that they will have diastolic abnormality. We can have like indeterminate kind of things, but their diastology can be purely normal. Now again, we have to comment on the diastolic function in this patient where E prime is abnormal. Look at the E by E prime, this is abnormal. We do not have a left atrial volume index here. TR velocity is abnormal, more than 2.8. So his diastolic function is normal or abnormal? Abnormal. And what about the filling pressures? Elevated, yes. So I've told you that comment on those two things simultaneously. Okay. Now you see, this is a patient, a 67-year-old male with heart failure, and you see here that E by E prime is less than 14 here. E prime is abnormal, less than 7. Levy is abnormal. TR velocity is abnormal. So this is a grade 1 kind of diastolic dysfunction. But 2 months back when he came in the emergency room, he came with E by E, which was clearly abnormal. Now what we are seeing is less than 14. At that time it was more than 14, and all the other parameters were abnormal. So 2 months back he was having a grade 2 abnormality. Now what we are seeing is grade 1 abnormality. That's why we have to state in our reports that when we are seeing the patient, what was when was his index admission was done, a day before, and after that during 24 hours he was extremely given intravenous diuretics, and his symptoms have improved in those 24 hours. So what has happened here is that he was given diuretics, so this picture becomes a grade 2 abnormality, becomes grade 1 abnormality. And similarly, if you give fluids, this grade 1 would become grade 2. So we have to very clearly say when we are seeing the patient. Otherwise, people who are looking at your comments would say, okay, patient came with pulmonary edema and you are saying the diastology is nearly normal. So how come that could be? Or systolic function is becoming better. How come that could be? We have to say that we are seeing the patient 24 hours after admission or after the index event. Okay, now we see this 51-year-old male. He came with dyspnea. He's hypertensive with CKD. His ECG was normal. You see that ejection fraction is nearly normal. His E to A ratio was 1.6. E prime is clearly abnormal. E by E is 15. TR velocity is abnormal. Levy is abnormal. IVC is 22. Collapse less than 50%. So see here, so what is he? Normal, grade 1, 2 or 3, and filling pressure is normal or increased. And filling pressures? Correct. So now you can easily comment on all these things. Another thing which is important is an L wave. Normally, when these L waves, when the patient is slightly bradycardic, but if you see an L wave which is more than 40 centimeters per second, that is clearly abnormal. So even in atrial fibrillation, I'll tell you when I reach atrial fibrillation level, even in atrial fibrillation, if you see L wave which is more than 40, that is abnormal. That indicates diastolic dysfunction. And especially this is very helpful in those cases where there is an indeterminate kind of diastology. Okay, I would move to difficult situations now. There are difficult situations in assessing the diastolic dysfunction because life is not very easy. When we are talking or when we are showing the slides, it looks very rosy, very nice and easy. But in actual practice, things become difficult. There is usually MAC or mitral annular calcification. There is atrial fibrillation, constriction can be there, hypertrophic can be there. And there we have to look at the pulmonary veins, Valsalva, isovolemic relaxation time and timing intervals, and strain, and that would help. You see here, this is a patient of hypertrophic cardiomyopathy. Very clearly, you see the E prime is abnormal, there is SAM, so clearly diastolic dysfunction is abnormal. Now this is a patient which I've seen very recently, a 50-year-old male, and you see here diastolic function is abnormal. There is no resting gradient across the LV outflow tract, but there was atrial fibrillation. So there are two things which were causing problem: atrial fibrillation and hypertrophic cardiomyopathy. And here you have to rely more and more on timing intervals, E prime, and then comment on the patient. So now we come to atrial fibrillation, which is a really very, very challenging thing when you are talking about the diastology. Whenever there is normally you see beat to beat variation, which is quite marked. But if you see a beat to beat variation which is not very much marked, then most likely their diastology is abnormal, their filling pressures are raised. Similarly, I have told you previously as well that IVRT should be looked upon. If it is less than 65, then this is abnormal. L wave becomes abnormal. And most importantly, we have to readjust our E by E prime value, because this one study showed that in atrial fibrillation, the cutoff value instead of 14 becomes nearly 11. So for atrial fibrillation patients, 11 as a cutoff value can be used in E by E prime. Levy cannot be used because in atrial fibrillation, left atrial volume becomes increased. Similarly, A wave is not present, so that's why pulmonary veins cannot be used in atrial fibrillation. So we have to be careful in checking in patients with atrial fibrillation. But there are certain things which can be used. Now there is a third algorithm, especially in patients with MAC. Whenever there is significant mitral annular calcification, like we have done in the second algorithm, you look at the E to A ratio and the E velocity. If this grade 1 kind of abnormality and E prime is abnormal, with MAC, the filling pressure is normal. If a restrictive type of pattern or grade 3 abnormality with E prime reduced, this shows that filling pressures are increased. But in patients where E velocity is slightly bigger, A is slightly smaller, the pseudo-normal kind of pattern, and E prime is reduced, but due to a significant MAC, you cannot really calculate the filling pressures, then you look at the isovolemic relaxation time, and the cutoff value is 80. If it is less than 80, then the filling pressures are elevated. These are the two examples you see here with significant MAC. IVRT is more than 90, so filling pressure is normal. And you see in this patient, again with significant MAC, IVRT is less than 60, so filling pressure is increased. Again, we can use diastolic stress test. We have to see that all the three things, E by E ratio and TR velocity, all of them should become abnormal with the diastolic stress test. it has been extensively used in the West, but in Pakistan we are not using a lot of it. It's not that difficult, but because of like cost and getting the proper things like this is really difficult. So we can use a passive leg raising test, elevate both legs passively perpendicularly to 45 degrees for 1 to 2 minutes. Now this transiently elevates preload by about 300 mil, and we can see that E prime becomes small and E to E ratio becomes abnormal. So you can use a modified kind of stress test. There are issues with the E velocity, or we have to be careful with the E by E ratio, or and left atrial volume index, as I have told you, with atrial fibrillation, MR, athletes, and increased output, and pulmonary hypertension, bundle branch block, or MAC with the E prime. So my take-home messages are that mitral annulus E prime is normal. There is normal diastolic function, most of the times. If E prime is reduced, that this is diastolic dysfunction. E by E prime and TR velocity, they are best to assess the diastolic function and increase filling pressure in most of the cases. The caveats are MAC, bundle branch block, and constriction, and severe pulmonary hypertension. We can use L wave. And one thing which is very important, because I have told you that there are two parameters, one is most specific and one is most sensitive. So if these two are abnormal, then probably in most of the cases where structural heart disease is present, you can comment upon diastology that this is abnormal. And we can do diastolic stress tests in selected cases. So we have to comment on whether diastology is abnormal or normal, which grade is that, and we have to comment very precisely on the filling pressures. And these are the four things which we would be using.
Pointed out 2 or 3 parameters. One is diastolic stress test, and the other is E dash by E values which are modified. The thing I want to point out is that for the juniors, that we have to also see the setting of the patient. At present, there are 2 types of scores available. One is called the HFpEF score, and the other is called the H2PEF score. So H stands for heavy, and the other H stands for hypertension, and then there is a score allotted for atrial fibrillation, and then for pulmonary hypertension. So we should think about correlating whenever we have such patients. Such patients are when patients have long-standing diabetes, long-standing hypertension, long-standing IHD, COPD patients, obese patients. So these are the sets of patients in which we have to look for the things pointed out by Dr. Shahbaz.
Dr. Salman, you are very right, but I just because these are very vast subjects, so heart failure with preserved ejection fraction is a very vast subject. And I specifically did not included these 2 scores, because then that would keep the volume of the talk very high. But like one very specific point is that when we are using these scores and trying to do the HFpEF present or not, anti-pro-BNP is very, very pertinent. So if you have anti-pro-BNP which is abnormal and this kind of abnormality, then HFpEF is present. And then we have to remember the anti-pro-BNP, especially in atrial fibrillation cases, they are going to be at least 3 times normal. Only then you can call them abnormal. So yes, whatsoever you are saying is very pertinent, but I think that we're going beyond the topic of the talk. Shahbaz.
Thank you. Thank you, Shahbaz, for an excellent presentation where you covered most of the things in diastolic dysfunction. Coming to your last slide, I'll just take a cue from there. Sometimes patients, for the sake of the others here, juniors, when patient comes to you and says that he or she is getting breathless, and you do an echo, you find the normal ejection fraction, the diastolic dysfunction, there is no significant diastolic dysfunction either. So I would suggest that just have the legs raised up and do a diastolic stress test like that, and you will actually be able to find out whether this patient has diastolic dysfunction and is this the cause of breathlessness in this patient. The other thing is that it's one of the very difficult situations is the atrial fibrillation.
Agreed.
And I think there you will be able to get it from the deceleration time plus the E by E prime.
Mm.
And in all such cases, in fact, in all cases, you must always find out the left ventricular filling pressure as to what it
Certainly.
is. And
Absolutely
then
right.
and write it down
Mm.
so that the person to whom the patient takes the echo back knows what to do with this patient.
Absolutely right.
this is
Totally
extreme-
agreed, because
This is
my stress
extremely
point
important.
is absolutely right. Doing a modified stress test in our kind of situations, just raising the legs and doing it properly is very, very helpful, especially in those patients which we are saying they are dyspneic but things look normal. And atrial fibrillation, the toughest area, defining diastology, and absolutely right. I totally agree. We have to do these things.
The other thing is that when we are looking at the E and the A wave, we must understand what are the hemodynamic changes which are taking place, because sometimes the E wave is very small, which means that the blood which was being passively filled is not able to go there, and the last bit of it is being pushed by the atrial kick.
Yeah.
Similarly,
So the A becomes bigger.
with the restrictive pattern, there is a rush of blood into the left ventricle, there's a spike there, and then the A wave is very small in these patients. And the reason for that is that equalization of pressure is there, and so no more blood can go there. So diastolic dysfunction may be very simple, but you need to actually understand the hemodynamics of it, and then you will be able to explain the things to your patient and manage the patients better.
Absolutely right, and we have to remember all this whatsoever Qureshi Sahab was saying, that heart failure, half of the patients are systolic, half are diastolic. So remember that we have to apply all these things.
All the patients with systolic have a diastolic.
Yeah.
Yeah. All the
Okay.
patients have a diastolic dysfunction.
Yes.
50% has the systolic dysfunction.
Yes.
Maybe the cause of the symptom is diastolic.
Yes. Thank you.